اوكي اوكي لا بي اوكي غير رأيه سي اوكي that's good. So upper endoscopy should be performed in all patients with liver cirrhosis to assess for presence of varices. This is a general rule, huh? So we do it for screening. What to do with the finding is as of the following, okay? When you have no varices, cool, that's good. We're just gonna continue the surveillance. So we'll repeat the endoscopy in 3 years. When you have a small varices, you would actually repeat it earlier, okay, in a couple of years. When you see small varices with the red wale marks, which is basically those erythematous raised area, so you start them in beta blocker, okay? And the goal is basically to decrease the pressure in the portal vein area, which subsequently hopefully decrease the pressure on the varices, preventing the bleeding. When you see large varices, more than 5 millimeter, you have two options, whether to initiate non-selective beta blocker or to do actually ligation, okay? When you cannot tolerate beta blocker, you have to do the varices ligation, okay? Resection of the esophagus, it's really not an option unless someone have an ongoing bleeding and you cannot control it with endoscopic intervention. Okay, so the non-selective beta blocker like the propranolol and nadolol, which can antagonize the beta-2 receptors to reduce the portal pressure, okay? So the answer would be the initiation of the propranolol, okay? Any question about varices bleeding? So don't forget about all patients actually require surveillance, so they require endoscopy. And then when the varices is being found, and if it's large, you offer them non-selective beta blocker plus or minus endoscopic intervention like ligation. Okay, ascites. For those who never seen ascites, this is a good example for it. You have a 68-year-old with a liver cirrhosis and ascites. He is non-adherence with her medication, present with abdominal pain, fever. Her blood work showed elevated bilirubin and elevated creatinine. Ascites tab was done, showed neutrophil more than 400. She was started on ceftriaxone. Which of the following intervention showed a survival benefit in her case? 1, lactulose orally. 2, albumin administration. 3, removing of the all ascites. What do you guys think? So let's first ask ourselves this question. What do you think the diagnosis is? Okay, someone is saying portal hypertension. Yes, طبعا الascites is a backflow from the portal hypertension. So what's led to the ascites is the portal hypertension. That's good. But now in this presentation, what do you think is going on? Okay. So this patient have, yes, infection. Good, good. So when you have an infection in the ascites, what do we call that? Hepatitis? No, not really. So this is what we call it, guys, spontaneous bacterial peritonitis. That's meaning we have an infection in the ascites, okay? Okay, so ascites can occur up to 50% of patient within 10 years of the diagnosis of cirrhosis, so it's quite common. So in each 2 cirrhotic patient, one of which at least will develop ascites in 10 years, and it's one of the most common complication of liver cirrhosis. When ascites is first detected, diagnostic paracentesis should be performed and the SAAG should be measured. Do you guys know what the SAAG is? So SAAG is serum albumin ascites gradients, okay? So you measure the serum albumin and you measure the albumin inside the ascites and then you subtract them from each other, okay? And why we are doing that? To differentiate and to try to know what's the driver and what the cause for the ascites. So be mindful for the units, okay? And I put the units here from the, let's call it the American versus the international. So 11 gram per liter is the international. So if you're gonna remember one, remember the 11. So when you have a high gradient, that's meaning there is a big difference between the serum and the ascites albumin. This is most likely portal related. So the next step would be checking the protein. So the first is checking the albumin gradient. The second is checking the protein inside the ascites. If you have a low protein, think about causes as cirrhosis, Budd-Chiari, or massive liver cirrhosis, massive liver metastasis. If you have high protein, think about congestive heart failure, constrictive pericarditis, early Budd-Chiari, IVC obstruction, so something beyond the liver organ. Okay, how to manage the ascites? This is generally speaking, we restrict their sodium to less than 2 grams per day. We give them diuresis, typically a combination of spironolactone and furosemide. Okay, now this spontaneous bacterial peritonitis basically should be considered in any patient with ascites who experience decline in condition, whether abdominal pain, fever, decompensated liver cirrhosis, okay? To make a diagnosis, we usually have to do acetic tab and a neutrophil account usually more than 250. Like in this case, we should initiate the antibiotic usually in a form of third generation cephalosporin like ceftriaxone as an initial treatment and follow the culture and adjust the antibiotic accordingly. In addition to the antibiotic, we give them albumin, 1.5 gram per kilogram in the first day, as well as 1 gram per kilogram in day 3. This actually showed a survival benefit. And take it an advice from me, guys. Whenever you hear a survival benefit, that's meaning it's an information that you should remember forever. That's meaning this intervention can save lives. Okay? So the answer for our case is basically giving albumin administration because he already been given the antibiotic. Any question, guys? So someone is asking, what's the benefit of albumin? Well, sometimes we don't know the benefits, but the albumin always been given in people with sepsis, for example, always been given for people with low blood pressure. So that may play a role, okay? But whenever we hear that giving this kind of fluid causing survival benefits, that meaning we should always consider it because it can save life. And someone asking, is it to bind the protein in particular? Well, albumin is a protein itself. So I would say perhaps it's through improving the circulation. Good question. Any other question, guys? Okay. Any other question, guys? Or shall we move on? Fine. Let's move on to the third topic, hepatic encephalopathy. Okay. So the development of hepatic encephalopathy can be spontaneous from the disease itself, but also can be precipitated by other conditions like infection, sedative medication, volume depletion, GI bleed. So whenever you see someone with a liver cirrhosis, they are presenting with hepatic encephalopathy, you really have to rule out those precipitants. Okay? Okay. So those just another illustration for the precipitant, basically. Don't forget about things like thrombosis, infection, AKI, dehydration, electrolyte imbalance, GI bleed, as well as hypoxia and hypercapnia. Okay? So how to treat hepatic encephalopathy? Well, we have to treat the precipitating factor, okay? If they have an infection, we have to treat it. If they have bleeding, we have to stop it. And that should be done promptly. We don't want them to enter a vicious cycle of hepatic encephalopathy, okay? At the same time, we should offer them lactulose, as the lactulose decrease the absorption of nitrogenous substance in the gut, which also reducing the encephalopathy burden, okay? If you give the lactulose, if you control and treat the precipitant, and you gave the lactulose, but still there is no perfect response, you may consider giving an antibiotic, rifaximin, to try to alter the bacterial flora in the intestine of the lumen. Okay? So, last but not least is a word about the hepatocellular carcinoma. Okay? Patient with cirrhosis, regardless of the cause, okay, require a surveillance for liver ultrasound every 6 months, which can lead to an early diagnosis and increase the rate of curative treatment and improve a 3-year survival rate for hepatocellular carcinoma. Okay, so we do that for screening as well as we do for the varicocele. Okay, so we do basically surveillance for varices as well as doing an ultrasound every 6 months to detect hepatocellular carcinoma early on so we can intervene early on. Any question, guys? Okay, if things are أيوة. We do imaging check for lifelong each 6 months in case lifelong. Good question. Lifelong, not only in the first 6 months. Good question. Okay, any other question? And if the condition get better, you mean the liver cirrhosis get better? Yeah, so liver cirrhosis, liver cirrhosis can get better. يعني they can go into decompensation وبعدين they go back to compensating, decompensation. But regardless, you will have to do an ultrasound every 6 months. طبعا, I would say that the exception is if they went to basically liver transplant, that's going to be the exception. But as far as they have liver cirrhosis, you will have to do an ultrasound. Okay. الله يعطيكم العافية جميعا. Next time it would be different. And بعدين أخذ منكم الفيدباك whether this work better or the other way after the next lecture. If you guys don't have any question, الله يعطيكم العافية. If you go over the top, if you went over the topic and if you have a question, please bring it during the next lecture. Okay? يعطيكم العافية شباب. وإياكم. يلا سلام عليكم.